Let's revise the Glasgow Coma scale and the Glasgow Outcome scale today. Let's begin with the former, which is GCS. It is one of, if not the most important scores for all of our exams, be it NEET, PG, INICET, even our ward postings. Yet, it is one of the simplest ones. So, let's go on to see how we can revise it very quickly. I remember the score as EVM 456. These are the three aspects tested in the Glasgow Coma scale, where E stands for the eye opening response, which is an indicator of the brainstem arousal but not necessarily an indicator of awareness. V stands for the verbal response, which is an indicator of the cortical function. And M here stands for the motor response. It is the most predictive for prognosis. So, out of the three components that we measure, M is the most important one for the patient. So, let us now expand upon the score and look at what each of these components mean. So, as we had discussed, E, V, M, 4, 5, 6. A score of 4 for the eyes opening response is the best response that a patient can have. A score of 5 is the best verbal response, and just like that, a score of 6, which is anyway the highest score on this scale, is the best motor response that a patient can show. If a patient is normally blinking, it is said to be that the patient is spontaneously blinking and they're opening their eyes spontaneously. This is given a score of 4, which is the highest for the eyes opening response. Please also take into consideration that the higher the score on this scale, the better the predictor. If the examiner asks a patient to open their eyes and they do so, give them a score of 3. If this doesn't work out and you have to give a stimulus to a patient, which could be in the form of pressure or pain, we give them a score of 2 when they open their eyes. If, despite all of this, the patient does not show an eye opening response, we give them a score of 1. Now, coming on to the verbal component, which has 5 heads to it. If a patient is oriented to time, place, person, talking normally to you, we give them a score of 5, which is the highest for the verbal part. If they seem to be a little bit confused and in a question it would sometimes be written as inappropriate language, we give them a score of 4. If a patient is only able to utter words and make sounds like moans, we give them a score of 3, and we assign a score of 2 if the patient is just able to make sounds or groans and they are even unable to form complete words. If a patient is not able to speak, then we give them a score of 1. Another interesting thing here to note is that a patient cannot speak when they are intubated, but that means that the speech was not testable. It is not that they weren't able to speak, but we couldn't test it. So that is known as a non-testable component here, and we denote it as VT or VNT. On examination of the patient, if they follow the commands given by the examiner, like moving a digit, we give them the best score on the scale, which is a score of 6. When the patient localizes the pain, we give them a score of 5. When the patient withdraws from pain, pain is a stimulus that we're giving to the patient. If they withdraw or flex away from the pain, we give them a score of 4. And when they assume abnormal posture, which would be a decorticate posture or abnormal flexion, we give them a score of 3. A score of 2 is assigned when the patient is in abnormal extension. This is also known as decerebrate posture. We'll talk about them a little while later. When the patient does not show a motor response, we give them a score of 1. Also note that the motor response is the best indicator of this score. Sometimes on the right side of the body, the patient may localize pain, and on the left side, the patient may withdraw from pain. When it comes to this, we always choose the better response. This entire scale is based on the best response that a patient gives and then calculating by adding the E, V, and M components of the scale. A modification to the GCS is the GCS-P score, where P is the pupillary unreactivity to light. Please note that I have said pupillary unreactivity to light. So P here basically stands for the number of pupils that are not going to react to light. The number of pupils that are not reacting to light can be zero. So a score of zero is the lowest possible score on this particular aspect of it. So when both eyes don't react to light, we give the patient a score of 2. If one eye reacts to light and one eye does not react to light, we give it a score of 1. And if both of the eyes are reactive to light, we give them a score of 0. Here, the thing to note is that this is not a hyphen, this is a minus sign. Say a patient has a GCS of 13 from the previous score that we had measured, and only one of their eyes is reacting to light. That means that a P score of 1 and a GCS score of 13 is taken here. So when we look at it, it's actually GCS minus P, which is 13, minus P score, which was 1. That would mean that the GCS-P score of this patient is 12. Always remember to subtract the P score from the GCS score if you are asked to calculate the GCS-P score here. When asked about the use of the GCS, it is so many things like monitoring the patient's response or the first assessment of a trauma patient that you have just seen in the emergency room, and the serial neurological assessment of a patient who has been admitted for a long time. The central point here is think neuro. So this is a score of neurological assessment of a patient. And as we had seen, the maximum and minimum points of the GCS and GCS-P scores would be somewhat like, since the GCS score was 4, 5, 6, if we add them, that means a score of 15 is the maximum that is possible. And as we had discussed in the GCS score, the lowest score for each of the components was 1. So 1 plus 1 plus 1 would be 3. The maximum score in the GCS-P score would be GCS score minus 0, correct? Because both the pupils were reactive to light, that would give a score of 0. That would again mean that the maximum score possible is 15. But the catch here is that the GCS score, which the minimum GCS score, which was 3, minus the maximum pupillary score, which was 2, would be 1. One of the major uses or one of the major inferences in the GCS is about brain injury, a little bit more inclined towards traumatic brain injury. A GCS of 13 to 15 is considered mild brain injury. A GCS of 9 to 12 is considered a moderate brain injury, and anything less than 8, which means 3 to 8, is a severe brain injury, and a patient almost always needs to be intubated when GCS drops below 8. Now let's again quickly check off the GCS-P score. This was EVM 4, 5, 6. So the eye opening response was spontaneous speech, pain, pressure, and no response. Verbal response was oriented, confused, words or moans, sounds or groans, and no verbal response. And another one which was non-testable in an intubated patient. The motor response 6 was the best one, which is obeying commands. Localizing pain was 5. Withdrawal from pain was 4. Abnormal flexion, decorticate posture, and 2 was extension, abnormal extension or decerebrate posture, and 1 was no motor response. And we had also discussed that the motor response is the best predictor of the neurological outcome. It's the best prognostic indicator. As we have just seen, the decorticate posture is abnormal flexion and decerebrate posture is abnormal extension. These images are really helpful to see what we mean by decorticate and decerebrate. One thing that's common in both of these images, as we can see, is that both of the lower limbs are extended and plantar flexed in both of the postures. Now, a simple trick to remember the decorticate posture is that the upper limbs are brought towards the core because this is abnormal flexion. So, since the lower limbs are the same in both the images, we need to look at the upper limbs for an easier diagnosis when it comes to a picture or a patient that we're seeing in front of us. The decorticate posture is because of loss of cortical inhibition of the red nucleus via the rubrospinal tract. Coming to the decerebrate posture, with the extended lower limbs, the upper limbs also are extended. So here the rubrospinal tract actually has been transected and the level of the lesion is below the red nucleus, which also means that the red nucleus is above the level of the lesion. Another funny trick to remember which one is the flexion posture and which one is the extension posture is just to count the number of E's. So as you can see that the decorticate spelling has 2 E's and only 2 of the limbs are extended, and the decerebrate spelling has 4 E's that I've highlighted in blue, and you can just see in the picture that all 4 limbs are extended. So now the pediatric version of the Glasgow Coma scale is just a modification of the GCS with age appropriate verbal cues. Adult and the pediatric GCS have all the same components for the eye response and almost all the same components for the motor response, only differing at the fifth point an adult where an adult would localize to pain, but the child, as normal children behave, would withdraw from being touched. Now, let's look at the differences in the verbal component of the pediatric GCS differing from the adult component. The best indicator would be a child would be smiling, talking normally. That would be a score of 5. Child who is crying a little bit but they can be calmed down would be given a score of 4. A child is persistently crying and they're not consolable at all, they're given a score of 3. And if they're able to just make agitated noises, grunts, they're restless, but they're not crying, that would be given a score of 2. And if the child shows no response, it's given a score of 1. Now we're done with the GCS, which was a huge chunk. The Glasgow Outcome Scale, or the GOS, is the aftermath of the head injury that we were evaluating while we were checking the GCS of a patient. So, this is the degree of recovery or the quality of life that a patient would probably have after recovering from this head injury. Here, the scale runs from 5 to 1, 5, of course, being the most desirable, best response possible. Here, we assign a score of 5 to a patient who has a good recovery and they are able to live a normal life. A patient with disability can be classified into two types, which are moderate disability and severe disability. We'd give a score of 4 to a patient when they have some disability but they are independent and they can live their life on their own. In a person with severe disability, we'd give a score of 3. Here, a patient is conscious but they are disabled. We'd give a score of 2 to a person who is in persistent vegetative state. They are a comatose patient and They're unconscious, speechless, and this may last for weeks or months, sometimes even years. The worst outcome on the Glasgow outcome scale is given a score of 1, and that is death. This was all about the Glasgow Coma scale and the Glasgow outcome scale. I hope that it was easy to revise both of these important scores. Thank you.